Welcome to the deep dive. Have you ever paused to consider how profoundly something as minuscule as a single gene can sculpt your entire health destiny?
It's pretty amazing when you think about it.
Right, it doesn't just dictate your eye color, it can fundamentally shape the very health challenges you might encounter throughout your life, often in, well, surprising ways. It's truly a mind-bending concept, isn't it?
Absolutely.
Okay, let's unpack this today because we're about to embark on a deep dive into a set of truly complex and fascinating conditions known as multiple endocrine neoplasia or MN syndromes.
Aren't the MN syndromes?
Our mission today is quite ambitious. We're taking what can feel like intensely dense, intricate medical textbook information, the very source material that medical professionals rely upon, and distilling it. Not just into clear, actionable knowledge, but into a framework that helps you master this information, understanding it like the elite professionals in the field.
That's the goal.
We want to offer you a shortcut to being not just well-informed, but truly knowledgeable, uncovering surprising facts and weaving in just enough, interest to keep you completely hooked on this intricate story.
And that pursuit of mastery is exactly why understanding these syndromes is so vital. They are a powerful, vivid illustration of the lifelong connection between our genetics and how diseases manifest in the body.
Okay.
At their core, MN syndromes involve specific, inherited genetic changes that lead to the development of tumors, some benign, but many critically malignant in our hormone-producing glands.
So endocrine gland specifically.
Exactly. These conditions affect individuals across their entire lifespan, demanding precise, often lifelong, proactive management.
Lifelong management, that's key.
Definitely. We'll primarily focus on the two main types, M type 1 or NN1 and Men type 2 or MN2. Each springs from distinct genetic origins. MN1 is linked to the menin gene,
Menin.
and MN2 arises from the RAT proto-oncogene.
Two different genes, two different syndromes.
Precisely. What's truly fascinating here, and essential for mastery, is grasping the inherent challenge and the incredible precision that's required. It's not just about diagnosing these lifelong risks, it's about proactively and effectively managing them, often with life-saving surgical interventions that are meticulously planned and executed.
So with that captivating overview, what does this all mean for us, the learner, trying to grasp the nuances of these syndromes? Let's start right at the foundational definition.
Good idea.
At their heart, MN syndromes are genetic conditions where inherited alterations in specific genes lead to the development of tumors within various endocrine organs and related tissues. These tumors can be either non-cancerous, which we call benign, or cancerous, known as malignant. The crucial point, the core takeaway, is that an individual carrying one of these genetic mutations faces a continuous lifelong risk of developing these tumors.
Right. It's not a one-off thing.
It's not a single event. It's an evolving risk profile that demands ongoing vigilance. And the genetic basis, as you highlighted, is absolutely central to understanding these conditions.
It really is.
Could you help us visualize the fundamental difference between how the menin gene malfunctions in MEN1 versus the RET gene in MEN2? Are we talking about like a crucial brake pedal failing or something else entirely?
That's an excellent way to frame it. Let's start with the MEN1 gene. You can find this gene at a specific address on our genetic map, chromosome 11q13.
11q13, okay.
It's responsible for creating a protein called menin, which is a complex molecule made up of 610 amino acids.
Menin protein.
Now, menin's role is absolutely critical because it functions as a tumor suppressor protein. Think of it exactly as you suggested, a crucial brake pedal for cell growth.
Ah, okay. The brake pedal idea works.
Its job is to regulate how cells grow and divide. When this gene is mutated and the menin protein loses its function, it's like those crucial brakes are removed, allowing cells to proliferate unchecked.
Uncontrolled growth.
This uncontrolled growth is what ultimately leads to neoplastic transformation, the development of tumors.
Got it. So MEN1 is about losing the brakes.
Exactly, loss of function. This raises an important question that speaks to the complexity of biology. How can a single protein, menin, have so many diverse and vital roles?
Yeah, that does seem like a lot for one protein.
It's truly remarkable. Studies have revealed that menin isn't just about stopping uncontrolled growth. It's involved in a wide array of cellular processes. It participates in what we call transcriptional regulation, acting as either a co-repressor or a co-activator.
So like turning other genes on or off?
Precisely. Essentially dictating the cell's behavior. Beyond that, menin plays a part in DNA repair, ensuring our genetic material stays healthy. It's involved in cell signaling pathways, helping cells communicate.
Communication, DNA repair.
And it helps maintain the internal structure of a cell, its cytoskeleton.
Yeah.
It even plays roles in cell division and how cells adhere to each other and move. These incredibly broad functions explain why a mutation in MEN1 can lead to such a wide array of affected tissues and organs throughout the body.
That makes sense now. So many jobs, so many potential problems if it fails.
Exactly. And to truly grasp how tumors develop in MEN1, we need to understand a concept called the two-hit hypothesis.
The two-hit hypothesis. Okay, I've heard of this.
Imagine you inherit a faulty copy of the menin gene from one parent that's your first hit. This doesn't mean you immediately get cancer. Instead, every cell in your body now carries one good copy and one faulty copy of the menin gene.
So you have a backup initially.
Right. While the one good copy is usually enough to keep things in check, it makes your tissues incredibly susceptible. Later in life, in a specific cell, a random second hit occurs. This could be another mutation or a loss of the functional gene copy within that particular cell. When this happens, both copies of the gene are now dysfunctional.
Both breaks are gone in that one cell line.
Exactly. Doctors call this loss of heterozygosity. Essentially, the cell has lost its two different gene copies and now only has non-functional ones. With no working menin protein left to act as that critical break, that cell loses its growth control and it's free to turn into a tumor.
And that's how the tumor starts, from that single double hit cell.
Precisely. This process is absolutely fundamental to how these hereditary cancers manifest over time. Our source material visually represents this process in figure 41.1, helping to cement that mental image.
Okay, the two hits. Inherited first hit, somatic second hit. Got it.
And it's not just endocrine tissues where menin plays a role. It has also been identified as what we call a pro-oncogenic factor in mixed lineage leukemia, or MLL.
Pro-oncogenic, so it can actually help cancer in some cases?
In certain contexts, yes. It means it can actually promote the development of certain types of leukemia by interacting with specific proteins. Intriguingly, menin has also been linked to regulating estrogen receptors, which explains why women with MEN1 have an increased risk for developing breast cancer. It truly underscores how a single genetic change can have such far-reaching and diverse impacts on health.
Wow. Okay, so that's MEN1, the broken brake pedal, the two-hit hypothesis. Now contrast that with RET and MNN2.
Right, let's switch gears to the RET proto-oncogene, the genetic culprit behind the MRE2 syndromes. The name RET itself stands for rearranged during transfection, which refers to how it was first discovered.
Okay.
This gene resides on chromosome 10q11.2.
Different location, chromosome 10.
And here's a crucial distinction from MNN1. Instead of a loss of function leading to tumors, mutations in RET are typically activating or gain-of-function mutations.
Gain-of-function. So not a broken brake, but maybe a stuck accelerator.
Exactly. That's a perfect analogy.
Yeah.
Imagine that accelerator pedal for cell growth now getting stuck in the on position or becoming hyperactive.
Okay, constantly signaling grow, grow, grow.
Precisely. The protein product of the RET gene is a membrane receptor with tyrosine kinase activity. When it's mutated, it continuously signals intracellular pathways that normally control cell growth and survival. This unregulated constant signaling leads to uncontrolled cell proliferation and ultimately tumor formation.
So MEN1 is loss of brakes, MNN2 is a stuck accelerator. Fundamentally different mechanisms.
Fundamentally different. The RET gene is particularly fascinating because it's expressed in multiple tissues that all originate from the neural crest.
Neural crest, embryonic cells, right?
Exactly. A specialized group of embryonic cells critical during development. This includes the parafollicular C cells in the thyroid, parathyroid glands, adrenal chromaffin cells, which are responsible for producing adrenaline, and various components of the nervous system, such as enteric ganglia in the gut.
Ah, so that explains the specific glands affected in MEN2. Thyroid, parathyroid, adrenal.
Precisely. This broad pattern of expression explains why MEN2 affects these specific organs. Its importance extends beyond disease. RET is crucial for normal development. For example, mice with mutated RET genes can develop kidney agenesis.
Kidneys don't form. Wow.
Meaning their kidneys fail to form and a lack of neurons in their digestive tracts. In humans, interestingly, inactivating RET mutations, the opposite of the activating mutations that cause MEN2 are associated with Hirschsprung disease.
Hirschsprung, that's a bowel issue in infants, right?
Correct. It's a condition where specific nerve cells are absent in the colon, leading to severe constipation and megacolon in infants. So, too much RET activity causes MEN2, but too little can cause other serious developmental issues.
Incredible. A gene with such a delicate balance. Too much is bad, too little is bad.
It really highlights the complexity.
That's a fantastic breakdown of the underlying genetics and the fundamental differences between MN1 and MNN2. So, bringing this from the microscopic to the macroscopic, what about the real-world prevalence of these conditions? How commonly do they occur, and what does that mean for diagnosis?
Good question, and it's important for putting this in context. When we look at incidence in epidemiology, MEN1 is considered relatively rare in the general population, affecting about 1 in 30,000 people.
1 in 30,000. Okay, pretty rare overall.
Yes, but its prevalence becomes significantly higher in specific patient groups where these tumors are common. For instance, among patients diagnosed with primary hyperparathyroidism, you'll find MEN1 in a notable 1% to 18% of cases.
So if you have hyperparathyroidism, the chance of it being MEN1 is much higher.
Much higher. And in patients with pituitary adenomas, less than 3% have MEN1. Clinical manifestations of MEN1 typically begin by age 29, though the diagnostic age range is quite broad, stretching from 9 to 77 years.
Quite a range.
Unfortunately, the mean age of death for MEN1 carriers is younger, around 50 to 55 years, although overall survival for diagnosed carriers is 82% at 30 years, with disease-specific survival at 88%.
Still a significant impact on lifespan, even with diagnosis.
Definitely. For MEN2, the estimated prevalence is quite similar in its rarity, at around 1 in 35,000 persons.
Also about 1 in 35,000.
Okay. But what has truly revolutionized the landscape for both conditions, and especially for MEN2, is the advent of genetic testing.
Ah, yes, genetic testing. This is where the game truly changed, isn't it? Moving from relying solely on clinical presentation to being able to pinpoint the exact genetic mutation. How has this transformed the approach, particularly for MEN1?
Absolutely. The transformation has been profound. For MEN1, commercial genetic testing for mutations has been available for over 30 years, marking a huge leap forward.
Over 30 years already. Wow.
Clinical guidelines strongly recommend genetic testing for anyone who is an index patient, meaning the first person in a family identified with this syndrome, as well as all their first-degree relatives.
Index patient and first-degree relatives. Makes sense.
This is crucial because MEN1 follows an autosomal dominant inheritance pattern. This means there's a 50% chance for each child to inherit the mutation if one parent has it.
50% chance. High risk.
Very high. It's also highly recommended to offer testing to asymptomatic relatives, precisely because clinical manifestations can begin as early as age 5.
Age 5, that's incredibly young.
It is. Identifying a mutation in an individual who hasn't yet shown symptoms allows for incredibly proactive surveillance and early intervention. Conversely, a significant benefit is identifying individuals without the mutation.
Right. They can avoid all that screening.
Exactly. They can avoid unnecessary lifelong screening and the associated anxiety. Now, it's important for Mastery to understand that even with conventional genetic testing, about 10% to 20% of patients who clinically present with MEN1 won't have an identifiable mutation.
So testing isn't perfect. 10-20% are missed.
By conventional methods, yes. In these specific cases, the diagnosis of MEN1 is made clinically, either when a patient presents with 2 or more of the classic MEN1-associated tumors, or with one such tumor and a first-degree relative who is definitively diagnosed with MEN1. This clinical diagnostic pathway accounts for about 5% to 10% of cases.
So clinical diagnosis is still important for some.
Definitely. A challenge unique to MEN1, however, is that generally we haven't established strong genotype-phenotype correlations.
Genotype-phenotype, meaning the specific gene change doesn't predict the specific symptoms.
Exactly. Unlike some other genetic conditions, simply knowing the specific MEN1 gene mutation a patient has doesn't reliably predict the exact course, the severity, or even the order in which different tumors will appear.
So the crystal ball is a bit cloudy for MEN1, even with the genetic test.
That's a good way to put it. While there are some emerging data linking specific mutations, for example, those targeting the gen-interacting domain of the gene to an increased risk of death, or certain alterations that might predispose only to familial primary hyperparathyroidism, genetic testing for MEN1 doesn't offer us that precise roadmap for an individual patient's disease progression. It guides surveillance, but not the specific unfolding of the disease.
Now here's where it truly gets interesting, and frankly, a game changer when we talk about MEN2 and its genetic testing. I recall you mentioning a much clearer picture there. What makes the genetic understanding so much more precise for MEN2?
You're absolutely right. This is one of the most powerful and exciting aspects of MEN2, the strong genotype-phenotype correlations with RET mutations.
Strong correlations. Okay, this is the key difference.
This is a fundamental difference from MN1. With MN2, knowing the specific RET mutation an individual carries allows us to predict the likely disease course, the anticipated age of onset for various tumors, and even the aggressiveness of the medullary thyroid cancer.
Wow. So you can actually tell someone, based on your specific RET mutation, you're likely to develop MTC around this age, and it might be more aggressive.
Yes, with a significant degree of accuracy. This is an incredibly powerful tool because it directly informs management. It guides decisions about prophylactic surgery, surgery performed to prevent disease, and enables highly tailored proactive care, which can truly be life-saving.
Prophylactic surgery, removing an organ before cancer even develops.
Exactly. And the penetrance of tumors, meaning the likelihood of them appearing for everything except medullary thyroid cancer, which is almost 100%, varies significantly depending on the specific RT mutation.
So the genetic test in MEN2 is much more predictive.
Far more predictive. Given this predictive power, the recommendations for RDT gene sequencing are broad and proactive. It is now the standard of care to offer genetic counseling and testing to all offspring of known MEN2 kindreds, ideally performed in infancy.
In infancy? Wow, that early?
Ideally, yes, for certain high-risk mutations. It's also recommended for first-degree relatives of patients with familial medullary thyroid cancer, or FMTC, which is a variant of MEN2.
Okay.
Furthermore, because de novo new mutations not inherited from a parent can occur, testing is crucial for patients with what appears to be sporadic, non-familial medullary thyroid cancer, as up to 7% might actually have underlying RED mutations.
So even if there's no family history, it's worth checking for RD if someone has MTC.
Absolutely. The same goes for individuals with apparently non-syndromic pheochromocytoma, as about 5% of these cases are found to be due to RT mutations.
Pheochromocytoma, too.
And finally, infants or young children presenting with Hirschsprung disease, or those with the distinct physical phenotype of MEN2B, and patients with cutaneous lichen amyloidosis should also be tested. This proactive testing strategy enables early, precise, and tailored interventions that can drastically alter the disease course and improve patient outcomes.
That's incredibly thorough. Before we dive into the specifics of MEN1's clinical features, you briefly touched on MEN4. I know it's a more recently identified syndrome, but it sometimes overlaps with what we're discussing. Could you give us a quick overview of that, just so our listener has the full picture?
Certainly. MEN4 is a more recently identified syndrome associated with germline mutations in the CDKN1B gene.
CDKN1B, another gene.
Right. Clinically, it's quite similar to MEN1, presenting with many of the same key features: parathyroid adenomas, pituitary adenomas, and pancreatic neuroendocrine tumors.
So it looks like MEN1 clinically.
It does. It's thought that MEN4 might explain some individuals who meet the clinical criteria for MEN1, but through conventional testing don't have an identifiable MEN1 gene mutation.
Ah, so it could be the answer for some of those 10–20%.
Potentially, yes. However, it's important to note that few pathogenic mutations of CDKN1B have been found so far, and its overall prevalence is still largely unknown. It's an evolving area of understanding in these complex genetic conditions.
Okay, good to know about MEN4, an emerging picture there.
Definitely.
With that incredible genetic groundwork laid, let's now explore how MEN1 actually manifests in the body, gland by gland, and the sophisticated ways it's managed. Just to reiterate, MEN1 is inherited in an autosomal dominant pattern, affects males and females equally, and if left untreated, it significantly decreases life expectancy with a 50% probability of death by age 50.
A serious condition, absolutely.
The symptoms, of course, mostly arise from either the overproduction of hormones by the affected glands or the local effects of the tumors themselves.
That's right. The most predominant feature and the first clinical manifestation in MEN1 is primary hyperparathyroidism, or PHPT.
PHPT, okay, number one feature.
It occurs in over 90% of MEN1 patients. And in a striking 90% of cases, it's the very first symptom they experience.
90%, and often the first sign. That's huge.
It is. If we connect this to the bigger picture for mastery, this makes PHPT an absolutely crucial and early screening point for MEN1.
Right. You need to think MEN1 if you see PHPT, especially if it's early onset.
Exactly. Patients might be completely asymptomatic, or they could present with a range of symptoms, including osteoporosis and bone weakening, kidney stones, fatigue, a general feeling of malaise, excessive urination and thirst, or constipation.
Classic hypercalcemia symptoms.
Pretty much. The diagnosis is made biochemically by finding elevated calcium levels in the blood and an inappropriately non-suppressed parathyroid hormone or PTH level.
High calcium, high or normal PTH.
Correct. Compared to sporadic PHPT, where typically only one of the 4 parathyroid glands is affected, PHPT and MEN1 has some key differences that are vital to understand.
Okay, how does MEN1-related PHPT differ?
It usually occurs at a much earlier age, typically between 20 to 25 years, compared to around 55 years in sporadic cases.
Much younger onset.
The gender ratio is also equal, 1.1 for female to male, versus a 3.1 female predominance in sporadic cases.
Equal gender ratio.
But most critically, the hallmark of PHPT in MEN1 is multiglandular disease.
Multiglandular, this is the big one, right?
This is the big one. This means that all 4 parathyroid glands are at risk for involvement, and they can show asymmetric enlargement or hyperplasia. While these tumors are almost always benign, rare cases of parathyroid carcinoma, a malignant tumor, have been reported in the context of MEN1.
So, usually benign, but affecting potentially all 4 glands. That must make surgery trickier.
It absolutely does. Surgery is the unequivocal treatment of choice for PHPT and MEN1. However, preoperative imaging, such as ultrasound, sestamibi parathyroid scintigraphy, or 4D-CT, which are incredibly useful in sporadic PHPT for localizing a single affected gland.
Where you're just looking for that one bad gland.
Exactly. Those scans have less utility here due to the multiglandular nature of the disease.
Because you expect all 4 might be involved anyway.
Precisely. That said, sestamibi might still be useful for finding ectopic glands, those not in their usual neck location. The recommended surgical approach for mastering this challenge is a standard open exploration of both sides of the neck to meticulously identify and address all 4 parathyroid glands because, as we discussed, they're all typically affected or at risk.
So you have to go in prepared to look at all 4.
You do. When it comes to the specific operative procedures, there are 2 main options surgeons consider. The first is a subtotal parathyroidectomy.
Subtotal. Removing most, but not all.
Right, where 3.5 of the 4 glands are removed, leaving a small remnant of parathyroid tissue behind. The main advantage of this approach is a lower likelihood of postoperative hypocalcemia, meaning low calcium levels, which can be a difficult complication.
Less risk of low calcium afterwards.
However, the trade-off is that recurrence of hypercalcemia or persistent disease is seen in about 20% to 30% of patients within 10 to 12 years.
High recurrence rate.
And hypoparathyroidism, requiring calcium and vitamin D supplementation, still occurs in 26% to 45%.
So, still a decent chance of needing supplements, even with leaving some behind.
Yes. The second option is a total parathyroidectomy,
Taking all 4 out.
where all 4 glands are removed, followed immediately by an autotransplantation.
Autotransplantation, putting some tissue back somewhere else.
Exactly. This means a portion of the patient's own parathyroid tissue is carefully transplanted into a non-neck location, most commonly the brachioradialis muscle of the forearm.
Into the forearm muscle. Why there?
It's easily accessible if you need to remove more tissue later due to recurrence, and it keeps the parathyroid function away from the potentially complex reoperative field in the neck.
Ah, smart.
This approach has lower recurrence rates, ranging from 4% to 20%, but carries a higher chance of permanent hypoparathyroidism, affecting 40% to 60% of patients.
Lower recurrence, but higher risk of permanently low calcium. A tough choice.
It is. While initial biochemical cure rates are remarkably high, reaching 98% in experienced surgical hands, a crucial insight for anyone truly mastering MNN1 is that MN1-related hyperparathyroidism is never truly cured if patients are followed long enough.
Never truly cured. That's sobering.
Recurrent disease is common and often requires reoperation, which can be more complex. Intraoperative PTH testing, where blood PTH levels are measured during surgery, can be used to guide the extent of surgery and confirm successful removal of abnormal tissue.
Checking PTH levels during the operation itself.
Yes, and cryopreservation of parathyroid tissue freezing and storing a small piece of it at the initial operation provides a crucial backup.
Freezing some tissue just in case.
This stored tissue can be used for a future autograft if needed to manage severe hypoparathyroidism later on.
Wow, a lot of planning involved in that parathyroid surgery for MN1.
Absolutely. Careful planning and experienced hands are key.
That's a lot to consider just for the parathyroid glands. What about the enteropancreatic neuroendocrine tumors, or NETs, which you mentioned have such significant malignant potential? How do these tumors present, and what are the specific challenges in managing them?
Indeed. Following parathyroid disease, Enteropancreatic NETs are the next most common tumor type in MNN1 patients, occurring in a significant 30% to 80% of individuals.
30 to 80%, another very common feature.
Very common. These tumors fall into two broad categories. Functional NETs, meaning they secrete excess hormones that cause specific symptoms.
Like gastrinomas or insulinomas.
Exactly. Or non-functional NETs, which don't produce excess hormones but still carry a significant malignant potential. Surgical management, when feasible, aims to achieve a few critical goals: controlling the excess hormone production, preventing the tumor from spreading, metastatic progression, and addressing any local invasion into surrounding tissues.
Control hormones, stop spread, deal with local invasion.
Right. Screening for these tumors typically involves biochemical markers like gastrin, fasting glucose and insulin, chromogranin A, pancreatic polypeptide, glucagon, and VIP, which are measured every 6 to 12 months.
A whole panel of blood tests regularly.
Yes. Any elevation in these markers triggers further radiographic studies to pinpoint the location of the tumor.
Okay, so blood tests first, then imaging if something's off. What kind of imaging?
When it comes to imaging these complex tumors, we've seen significant advancements. Somatostatin receptor scintigraphy, or SRS, using indium-labeled octreotide, was historically considered the gold standard.
SRS, or octreoscan.
Right. It's a whole-body scan, highly specific, nearly 100%, but it have a limitation. Its resolution struggles to detect lesions smaller than 1 centimeter.
Can miss small tumors.
Computed tomography, or CT, is now very widely used. It offers similar sensitivity to SRS, but is much better at detecting extrahepatic metastases, meaning spread outside the liver.
CT is better for spread outside the liver.
CT is also crucial for surgical planning because it clearly shows the tumor's relationship to surrounding structures. Magnetic resonance imaging, or MRI, provides similar anatomic detail to CT, but without the ionizing radiation.
Good for repeated scans over time.
Exactly, making it an excellent choice for long-term follow-up. For a comprehensive picture, doctors often use gadolinium-enhanced MRI with multiple phases, including pre-contrast, arterial, and portal venous phases.
Multi-phase MRI. Okay.
Endoscopic ultrasound, or EUS, is a particularly crucial imaging modality for pancreatic NETs.
EUS ultrasound from inside the stomach or duodenum.
Precisely. It offers superior visualization of the tumor's margins, especially those near critical structures like the superior mesenteric artery. EUS also allows for tissue diagnosis through a fine needle aspiration, or FNA.
Getting a biopsy at the same time.
Right, where a tiny tissue sample is taken. This sample is vital for determining the tumor's grade using something called the Chi-67 index.
Chi-67. That tells you how fast the cells are dividing.
Exactly. It tells us how rapidly the tumor cells are proliferating, and that's how aggressive the tumor might be. However, EUS is less useful for duodenal gastrinomas.
Not as good for the duodenum ones.
The very latest addition to our imaging arsenal is gallium-68 somatostatin analog PTCT, or 68-GASA-PET-CT.
Gallium PTCT. I heard a lot about this recently.
It's a powerful tool. This advanced scan fuses the functional information from PT with the anatomical detail from CT. It boasts around 80% sensitivity and 90-100% specificity for detecting metastases, and is increasingly valuable because it can even help predict a patient's response to somatostatin analog therapies.
So it finds tumors and predicts treatment response.
Potentially, yes. However, it can sometimes produce false positives from normal uptake in the uncinnator process of the pancreas or from inflammation.
So need to interpret it carefully.
Always. Let's delve deeper into specific types of functional NETs, starting with gastrinomas. These account for about 50% of enteropancreatic NETs in MNN1.
Half of the PNETs are gastrinomas.
And notably, 20% of all gastrinomas, even those not initially linked to MNN1, are found to be MNN1 related.
So 1 in 5 gastrinomas overall are actually due to MNN1.
That's right. Gastrinomas lead to a condition called Zollinger-Ellison syndrome, or ZES. Patients experience severe, recurrent peptic ulcers, often unresponsive to standard therapy, as well as abdominal pain and esophagitis. These ulcers can appear in atypical locations.
Really bad ulcers, hard to treat. ZES.
The diagnosis is made by finding significantly elevated fasting serum gastrin levels, often more than 10 times normal, ideally measured after the patient has been off proton pump inhibitors for at least 2 weeks.
Super high gastrin levels off PPIs.
If needed, a secretin stimulation test is highly sensitive and specific in confirming the diagnosis, more so than a calcium stimulation test.
Secretin test to confirm.
The malignant potential of MEN1-associated gastrinomas is high, up to 90% are malignant.
90% malignant, wow.
And over 50% already have lymph node metastases at diagnosis. The development of liver or lymph node metastases is clearly dependent on the size of the primary tumor, Larger tumors carry a higher risk.
Size matters for spread.
While overall survival without liver metastases approaches 100% at 15 years, it drops significantly to 52% with liver involvement.
Liver mets are really bad news for survival.
Definitely. The management of gastrinomas in MEN1 is quite controversial among experts. There's no broad consensus on the precise role of surgery because achieving long-term normalization of gastrin levels, known as eugastrinemia, is rarely successful through surgery alone.
So surgery might not cure the high gastrin levels?
Rarely does long-term. Proton pump inhibitors are highly effective in managing the symptoms. Interestingly, correcting the primary hyperparathyroidism can even help improve gastrin and acid levels.
Fixing the parathyroid helps the stomach acid. Interesting connection.
It can. The ongoing debate over surgery primarily centers on its malignant potential. Since most gastrinomas originate in the duodenum, surgical approaches might include endoscopic gastroduodenoscopy, a duodenotomy to explore the first part of the small intestine, and resection of any malignant lymph nodes.
So surgery is more about stopping the cancer spread than curing the hormone excess.
Often, yes. Our source material, figure 41.4, provides a helpful visual of this surgical approach. It's important to know that liver metastases are rare if the primary tumor is under 2 centimeters. Surgical decisions are highly individualized, weighing the risk of recurrence, the potential for multiple tumors, and the high morbidity associated with major pancreatic resection.
Balancing act between cancer risk and cervical risk.
Exactly. Patients with chronic hypergastrinemia also risk developing type 1 gastric carcinoids, which are often managed with observation and endoscopic resection.
Another tumor risk from the high gastrin.
Moving on to insulinomas, which are beta islet cell tumors, they make up to 30% of MEN1-associated PNETs.
Insulinomas. Cause low blood sugar, right?
Precisely. While about 4% of all insulinomas are MEN1 related, these tumors cause the classic Whipple triad, fasting glucose levels under 50 milli-GDL, accompanying hypoglycemic symptoms such as sweating, dizziness, confusion, or even fainting, and the resolution of these symptoms with glucose administration.
Whipple triad. Low sugar, symptoms, sugar fixes it.
Diagnosis traditionally involved a monitored 72-hour fast, but a 48-hour fast is now considered equally adequate and accurate, where plasma glucose, insulin, and C-peptide levels are measured.
A monitored fast to catch the low sugar and high insulin together.
It's also crucial to meticulously exclude the use of any oral hypoglycemic agents, which could mimic the symptoms.
Rule out diabetes pills causing it.
Localizing insulinomas can be quite challenging because they are often multifocal, meaning they appear in multiple spots and can be distributed throughout the pancreas.
Hard to find, often multiple tumors.
While CT and EUS are used for imaging, their sensitivity for these specific tumors is often less than 50%. A calcium arterial stimulation test is a valuable tool with over 90% sensitivity and is very useful for regionalizing the lesion, helping to narrow down its location before surgery.
Calcium stimulation test helps find the region.
During surgical exploration, intraoperative ultrasound is key for identification, boasting an 86% success rate, as shown in figure 41.5 in our source.
Ultrasound during surgery is the best way to find them?
Rapid insulin assays performed on fluid aspirated from a suspected lesion can confirm the diagnosis in real time during surgery.
Checking insulin levels right there in the OR. Cool.
Many insulinomas are amenable to enucleation, which means removing just the tumor itself while preserving the surrounding pancreatic tissue.
Just scoop out the tumor, if possible.
However, larger or malignant tumors, which account for about 10% of cases, may require an anatomic pancreatic resection, meaning removal of a section of the pancreas.
Bigger surgery for bigger or cancerous ones?
For unresectable disease, chemotherapy, including somatostatin analogs, may be used to manage the tumor growth.
Meds if surgery isn't an option.
Other functional PNETs, while less common, comprising fewer than 5% of functional PNETs in MN1, include glucagenomas, viipomas, and somatostatinomas. Each has its unique presentation.
The rarer ones. Glucagenomas.
Glucagenomas often manifest with necrolytic migratory erythema, a distinct skin rash, along with weight loss, anemia, and inflammation of the mouth. They are usually found in the pancreatic tail and are frequently malignant, with 50% to 80% having metastases at diagnosis, making surgery the primary treatment.
Distinct rash, often malignant. Vipomas.
Vipomas, though infrequent, cause severe intermittent watery diarrhea, low potassium levels, absence of stomach acid, acidosis, flushing, and hypotension. They too are often in the pancreatic tail and are almost always malignant, best managed surgically when feasible.
Really bad diarrhea, almost always malignant. Somatostatinomas.
Somatostatinomas are also rare, presented with gallstones, diabetes, and steatorrhea, diagnosed biochemically and also primarily treated surgically.
Gallstones, diabetes, fatty stools, surgery again.
It's important to know that the majority of enteropancreatic nets in MNN1 patients are actually non-functional.
Most don't make active hormones.
Right. This means they don't secrete excess hormones and are typically discovered incidentally during surveillance imaging or due to the local effects of the tumor growing.
Found by chance on scans.
Screening for enteropancreatic nets in MN1 patients with known mutations should begin at age 10. There's even newer data suggesting that specific mutations in exon 2 of the MNN1 gene may correlate with an earlier onset of these non-functional PNETs, potentially warranting earlier or more frequent screening for that particular subset of patients.
Start screening at 10, maybe even earlier for some mutations.
Management recommendations for non-functional PNETs in MN1 require a delicate balance between the potential for multiple tumors and the significant malignant potential of these lesions. Similar to sporadic non-functional PNET, decisions are based on tumor size and its grade.
Size and grade again.
Which is assessed by factors like the mitotic index and the Ki-67 index, indicating how quickly cells are dividing and thus the tumor's aggressiveness. Observational studies show a clear correlation between tumor size and the risk of metastasis. Only 4% for tumors under 1 centimeter.
Low risk of small.
But this jumps to 10% for 1.1 to 2 centimeters, 18% for 2.1 to 3 centimeters, and a significant 43% for tumors larger than 3 centimeters.
Risk really climbs after 2 centimeters, especially after 3 centimeters.
Exactly. Current consensus recommends observing tumors less than 2 centimeters with regular imaging, primarily due to the significant morbidity and potential complications associated with pancreatic surgery.
Watch and wait if under 2 centimeters.
Surgery is generally recommended for tumors larger than 3 centimeters, as observation in these cases is unfortunately linked to increased mortality and metastasis.
Operate if over 3 centimeters.
For tumors falling between 2 and 3 centimeters, the decision for surgery is less clear-cut and is often made based on evidence of significant growth, any signs of metastasis, or specific patient factors that might favor intervention.
The 2-3 centimeter range is a gray area. Needs careful consideration.
Very much so.
That's an incredible depth of detail for the enteropancreatic tumors. Now, let's turn our attention to another crucial gland involved in MEN1, the pituitary. How do pituitary adenomas manifest, and what are the management strategies for them?
Pituitary gland adenomas are indeed common in MEN1, occurring in 15% to 50% of patients, typically between ages 20 and 40.
15-50%. Also common, later onset than PHPT usually.
Right. While they are a significant feature of MEN1, it's worth noting that only about 1% of all pituitary adenomas diagnosed generally are MEN1 related, and they're usually not the very first manifestation of this syndrome.
So most pituitary tumors aren't MEN1.
Correct. These tumors can cause symptoms either through the excess secretion of hormones, most commonly prolactin, growth hormone, or corticotropin, or from local effects as the tumor grows and presses on surrounding structures, such as leading to visual field defects.
Hormone problems or vision problems.
The majority of these tumors are benign and unifocal, meaning they occur as a single lesion. Screening for pituitary involvement typically involves biochemical tests beginning at age 5, along with MRI evaluations of the pituitary gland every 3 years.
Screening starts young, regular MRIs.
Treatment generally mirrors that for sporadic pituitary adenomas, utilizing both medical and surgical therapies to control hormone excess or to relieve mass effect.
Treat them like regular pituitary tumors, basically.
Essentially, yes. Finally, to complete our understanding of MEN1, the syndrome can be associated with a variety of other tumors throughout the body.
Okay, what else can show up?
These include carcinoids of the thymus, bronchi, and gastrointestinal tract, as well as adrenocortical tumors, and even cutaneous manifestations like lipomas, facial angiofibromas, and collagenomas.
Carcinoids, adrenal tumors, skin things.
Thymic carcinoids are particularly noteworthy because they are the most likely to be malignant and can be quite aggressive, carrying a poor prognosis with only a 45% 10-year survival rate.
Coalomic carcinoids. Those sound dangerous.
They can be. They occur twice as often in men compared to women and have been linked to smoking. While there's no single optimal screening method, regular CT and MRI scans every 1 to 2 years are often recommended for earlier detection, and surgery is the preferred treatment when feasible.
Screen with scans, operate if found. What about that thymectomy idea?
It's important to clarify a past practice. Prophylactic transcervical thymectomy, which was once considered to prevent thymic carcinoids or remove additional parathyroid tissue, is no longer recommended, as studies have shown no identifiable carcinoids in patients who underwent this procedure.
So removing the thymus preventatively didn't really work?
Correct. Adrenocortical tumors are also quite common in menin 1, with approximately 20% of patients having some form of adrenal hyperplasia.
Adrenal glands involved too.
These can be functional, producing excess hormones, or non-functional, and they can be benign or malignant. Compared to sporadic cases, menin 1 patients have a higher frequency of adrenocortical carcinoma, a rare and aggressive adrenal cancer, and primary hyperaldosteronism.
Higher risk of adrenal cancer in MEN1.
There are currently no specific established guidelines for managing adrenal tumors in MEN1, so general guidelines for adrenal masses apply. Surgery is generally indicated for tumors 4 centimeters or larger, those with suspicious radiological features, tumors producing excess hormones, or those showing significant growth over a 6-month imaging interval.
Standard adrenal tumor guidelines. Operate if large, suspicious, growing, or making hormones.
Right. The cutaneous tumors, like lipomas and angiofibromas, are generally benign and typically do not require treatment, though they can sometimes aid in the clinical diagnosis of MEN1 if other features are present.
Skin findings are mostly cosmetic, but can be clues.
Exactly.
Now, let's pivot to MEN2, a syndrome that, while also genetic, offers a clearer and more precise roadmap for prediction and intervention, all thanks to its strong link to a single gene.
Right, the RET gene.
MEN2 is subdivided into 3 main clinical presentations: MEN2A, MEN2B, and familial medullary thyroid cancer, or FMTC. What all these subtypes share in common is a central, almost universal hallmark: medullary thyroid cancer, or MTC.
MDC, the big one for MEN2.
Which occurs in nearly 100% of patients with MEN2. Here's where it truly gets interesting, as we hinted at earlier. The genotype-phenotype correlation in MEN2 is remarkably strong, unlike what we observe in MEN1.
This is the key.
This precision in genetic understanding fundamentally transforms how these conditions are managed, allowing for truly proactive and often preventative strategies. What are the key distinctions between these 3 MEN2 subtypes?
Absolutely. Let's break down the MEN2 syndromes and their defining characteristics. MEN2A is the most common subtype. Its defining features are medullary thyroid cancer, which has over 90% penetrance.
Almost everyone gets MTC.
Pheochromocytomous tumors of the adrenal glands in 50% to 60% of patients, and parathyroid tumors leading to primary hyperparathyroidism in up to 30%.
MEN2A, MTC, pheo, parathyroid.
Importantly, patients with MEN2A typically have a normal physical appearance.
Look normal externally. Okay, MEN2B.
In contrast, MEN2B also presents with MTC and pheochromocytomas, occurring in about 50% of patients, but critically, it does not include primary hyperparathyroidism.
MEN2B, MTC, pheo, but no parathyroid.
Correct. Instead, MEN2B patients have a very distinct physical appearance, often described as marfanoid, with an elongated facial structure, averted eyelids, other ophthalmologic and skeletal abnormalities, characteristic mucosal neuromas, benign nerve tumors on the lips and tongue.
Those little bumps on the lips and tongue.
Yes, and widespread ganglioneuromatosis throughout the gastrointestinal tract, leading to issues like esophageal dysmotility and bowel problems.
So a very specific look. And GI issues.
The MTC in MEN2B is also typically more aggressive and has a much earlier onset compared to MEN2A.
More aggressive MTC in MEN2B. Okay, what about FMTC?
Familial medullary thyroid cancer, or FMTC, is generally considered a variant of MEN2A, rather than a completely separate entity. It's characterized by MTC occurring in families with a RET mutation, but crucially, without any history of pheochromocytoma or primary hyperparathyroidism in those families.
FMTC. Just MTC, no pheo, no parathyroid.
Exactly. While all FMTC patients will eventually develop MTC, they are generally diagnosed later in life, typically in their mid-40s, which is about 20 years later than MTC and MEN2A.
Later onset MTC may be less aggressive?
Possibly, yes. This suggests that FMTC may be a less aggressive form of MTC. However, clinicians are cautioned to accurately differentiate FMTC from MEN2A, as misdiagnosis could lead to overlooking a potentially present pheochromocytoma, which carries significant life-threatening risks.
Gotta be sure it's really just FMTC and not MEN2A hiding.
Absolutely critical. Revisiting the RET proto-oncogene for MEN2, as we discussed earlier, it is the activating missense mutations in RET that are the fundamental cause of MEN2 syndromes.
The stuck accelerator.
Right. The profound significance of this lies in the incredibly strong genotype-phenotype correlations we observe. This means that specific RET mutations allow us to predict with remarkable accuracy the likely disease course, the anticipated age of onset for various manifestations, and even the aggressiveness of the medullary thyroid cancer.
Predictive power.
This precise genetic information is a game changer because it directly guides surveillance strategies and, crucially, informs decisions about prophylactic surgery, which can be life-saving. As I mentioned, the penetrance of tumors, which is the likelihood of them appearing for everything except MTC, which is nearly 100%, varies significantly depending on the specific RET mutation an individual carries.
So the specific RET change tells you a lot.
A huge amount. Beyond the primary tumor types, MEN2A and FMTC can also be associated with other, less common conditions. Cutaneous lichen amyloidosis, for example, is uncommon, but often occurs with specific mutations like codon 634.
That itchy skin thing again.
It presents as itchy, often on the back skin plaques, due to the deposition of amyloid protein. Another associated condition is Hirschsprung disease.
Hirschsprung again. Linked to MEN2A sometimes.
Yes. This is characterized by the congenital absence of ganglion cells, specific nerve cells, in the distal colon, leading to megacolon and severe constipation. It occurs in about 7% of MEN2A patients. It's important to remember for mastery that Hirschsprung disease outside the MEN2 context is due to inactivating RET mutations, a direct contrast to the activating mutations that cause MEN2. This highlights the gene's diverse roles.
Activating RET for MEN2, inactivating RET for Hirschsprung. Fascinating.
For MEN2B, the genetics are quite specific, often leading to its distinct presentation. The vast majority of MEN2B patients, over 95%, have a specific germline mutation in exon 16 at codon 19, commonly referred to as the M9ATT mutation.
M9ATT, a main MEN2B mutation.
A smaller percentage, fewer than 5%, have A8NE83F mutations, which are associated with the generally milder, less aggressive form of MTC.
A slightly less severe variant.
What's particularly crucial to grasp, especially for proactive management, is that approximately 50% of MEN2B cases are due to de novo mutations.
Half are brand new mutations, no family history.
Exactly. They arise spontaneously in the affected individual and are not inherited from a parent, so there might be no known family history of the condition. This highlights why genetic testing is so critical, even in the absence of the known family history. If the clinical presentation strongly suggests MEN2B,
Can't assume no MEN2B just because the parents are unaffected.
correct. This brings us back to genetic testing for MEN2, which is truly a cornerstone of a proactive approach. The standard of care is now sequencing the RET gene, focusing on specific coding regions related to the suspected MEN2 type.
Standard of care now.
This allows for early identification of carriers, even in infancy for offspring of known kindreds and first-degree relatives of those with FMTC. This raises an important question. Who exactly should be tested to achieve that elite level of proactive care?
Right. Who needs the RET test?
Beyond those with a clear family history, individuals with apparently sporadic medullary thyroid cancer should be tested, as up to 7% will actually have a UNT mutation.
Anyone with MTC.
Similarly, around 5% of patients with apparently non-syndromic pheochromocytoma, a tumor of the adrenal gland, also have RET mutations.
Anyone with a pheo.
Other strong recommendations for testing include infants or young children presenting with Hirschsprung disease, parents of children with a distinct physical phenotype of MEN2B, and patients presenting with cutaneous lichen amyloidosis.
Kids with Hirschsprung, kids who look like MEN2B, people with that skin condition. Broad testing recommendations.
Very broad, reflecting the importance of early detection. This comprehensive, proactive testing strategy enables early, precise, and highly tailored interventions that can drastically alter the disease course and significantly improve patient outcomes.
Medullary thyroid cancer is arguably the most critical component of MEN2, given its near universal presence in these patients and its potential for aggressive behavior. Okay, let's unpack this. What makes MTC so fundamentally different from other thyroid cancers we might be more familiar with, and why does that matter for how it's treated?
That's a crucial distinction, and understanding it is key to mastering MTC. Unlike papillary and follicular thyroid cancers, which arise from the follicular cells of the thyroid and respond well to treatments like thyroid-stimulating hormone suppression or radioactive iodine.
The common types of thyroid cancer.
Right. MTC originates from a completely different cell type, the parafollicular C cells of the thyroid.
C cells, not follicular cells.
These C cells produce a hormone called calcitonin, and here's the critical difference. They are not iodine sensitive.
Not iodine sensitive. That's huge.
It is. This means that traditional treatments like radioactive iodine, which are highly effective for other thyroid cancers by targeting iodine-avid cells, are completely ineffective for MTC.
So radioactive iodine is useless for MTC.
Completely useless. Approximately 25% of MTC cases are familial, meaning they are inherited, and these cases are often preceded by a condition called C-cell hyperplasia, which is an overgrowth of these calcitonin-producing cells.
A precursor stage in familial cases.
While MTC is generally considered an indolent malignancy, meaning it tends to grow slowly, there are significant differences in prognosis depending on the specific MEN2 subtype. For instance, in one large database, the overall 10-year survival for MTC was reported as 84.4%.
Okay, overall survival.
However, survival was notably worse for MEN2B patients at 60% at 10 years, compared to sporadic MTC at 80.4% and MEN2A at 94%.
Much worse survival for MEN2B MTC confirms its aggressiveness.
Absolutely. This highlights the increased aggressiveness of MTC in MEN2B. Independent predictors of worse outcomes for MTC include male sex, a tumor size larger than 1 centimeter, and the presence of lateral neck lymph node metastases.
Male, bigger tumor spread to side of neck, worse prognosis.
Correct. Clinically, MTC may present as a central neck mass that a patient or doctor can feel. Or it might cause local symptoms like difficulty swallowing, breathing issues due to compression of the windpipe, or hoarseness if the tumor invades surrounding structures like the recurrent laryngeal nerve.
A lump or compression symptoms.
In familial cases like FMTC, the tumors tend to be multifocal, meaning they rise in multiple locations within the thyroid gland. Diagnosis is typically confirmed with a fine needle aspiration biopsy,
FNA biopsy.
where a tiny sample of the thyroid nodule is taken. Under the microscope, this reveals parafollicular cells and usually stains positive for calcitonin and amyloid-like material, which is a hallmark feature of MTC.
Specific look on the biopsy.
It's a sobering fact that nearly half of patients diagnosed clinically, rather than through proactive calcitonin screening, already have lymph node metastases.
Half have spread to nodes if found clinically. Yikes.
It underscores the need for early detection. It's therefore essential to meticulously evaluate for lymph node disease in both the central compartment of the neck, known as level 6, and the lateral compartments, which include levels 2, 3, 4, and V.
Check nodes in the center and sides of the neck.
Unfortunately, MTC that has spread to distant sites outside the neck, commonly to the liver, bone, and lungs, is generally considered incurable. These distant metastases may be occult, meaning hidden, with elevated serum calcitonin being the only initial sign.
Distant spread is usually incurable.
Their presence significantly worsens prognosis, with reported survival rates of 51% at 1 year, 26% at 5 years, and only 10% at 10 years.
Very poor survival with distant mets.
Since these C cells secrete calcitonin, this hormone serves as an incredibly useful biochemical marker for both diagnosing MTC and, crucially, for monitoring recurrence after treatment, as virtually all MTCs produce it.
Calcitonin, the key blood marker for MTC.
While provocative pentagastrin stimulation tests were historically used for screening, they are no longer available in the United States. After surgical treatment, postoperative calcitonin levels are critical for determining the presence of any persistent or recurrent disease, whether it's regional in the neck or distant.
Checking calcitonin after surgery tells you if any is left.
Carcinoembryonic antigen, or CEA, is another marker produced by some MTCs. While less useful for initial diagnosis, it's very valuable for monitoring patients for recurrence after thyroidectomy.
CEA is another marker to watch for recurrence.
For imaging MTC, neck ultrasound is the most sensitive method for detecting primary tumors and suspicious lymph nodes in the neck, and it's excellent for guiding fine needle aspiration biopsies.
Ultrasound is best for the neck itself.
CT scans of the neck, chest, abdomen, and pelvis are useful for comprehensive surgical planning, especially with bulky disease, to assess any extension into the mediastinum or vascular invasion. Importantly, iodinated contrast used in CT is not an issue here, since radioactive iodine is not used in MTC treatment.
CT is good for planning big surgeries and checking spread. Contrast is okay.
CT is also particularly good for detecting distant metastases. MRI is helpful for evaluating liver metastases or further characterizing suspicious liver lesions identified on CT.
MRI for liver details.
And as we discussed earlier, 68-GASA PET-CT is emerging as an important adjunct, especially for MTCs that express somatostatin receptors, aiding both lesion detection and potentially guiding targeted therapeutic planning, predicting which tumors might respond to somatostatin analog therapies.
gallium PET again for finding disease and maybe guiding therapy.
Right, yeah.
So, given all these unique characteristics and the aggressive potential of MTC, how does the surgical management differ, especially when we're talking about inherited syndromes? It sounds like it's a highly tailored and critically timed intervention.
It truly is a masterclass in tailored surgical precision. Surgery for MTC and MEN2 patients occurs in two primary settings, either for clinically apparent disease, where a thyroid nodule or enlarged cervical lymph nodes are found on examination or imaging,
Treating cancer that's already there.
or as a preventative prophylactic measure in RET mutation carriers to limit tumor spread and significantly improve overall survival.
Or preventing it before it starts or spreads.
For those with clinically evident disease, meticulous preoperative preparation is absolutely key. This includes a biochemical evaluation of calcitonin and CEA levels before surgery, which serve as crucial baseline markers to assess the completeness of resection postoperatively.
Get baseline calcitonin and CEA first.
But most critically, all patients must undergo screening for pheochromocytoma using plasma or 24-hour urine metanophrins before MTC surgery.
Rule out pheo before thyroid surgery. Absolutely critical.
This is absolutely essential to avoid a potentially fatal hypertensive crisis during the operation, as removing a pheochromocytoma can release a flood of hormones that can destabilize blood pressure. If a pheochromocytoma is identified, adrenalectomy is almost always performed first to normalize catecholamine levels before proceeding with any other surgeries.
Pheo surgery comes first. Always.
Almost always. Imaging, including neck ultrasound and contrast-enhanced CT or MRI, is used to assess the full extent of tumor involvement. If baseline calcitonin levels exceed 500 pgml, cross-sectional imaging of the chest, abdomen, and pelvis is strongly recommended to evaluate for distant metastases, even if there are no other symptoms, because the risk is so high.
High calcitonin means scan the whole body for spread.
Correct. In terms of the extent of surgery for clinically evident MTC, a total thyroidectomy is the absolute minimum operation for all MTC patients.
Minimum is remove the whole thyroid, no less.
This is because nearly 90% of familial MTC cases involve both lobes of the thyroid and are multifocal, meaning they arise in multiple distinct locations within the gland. The initial operation must always include a compartment-oriented bilateral central level 6 lymph node dissection.
I'll always take out the central neck nodes too, level 6.
To give you a mental image, this involves meticulously removing all lymph node tissue en bloc from the hyoid bone superiorly down to the innominate vein inferiorly, bounded by the carotid sheaths laterally, and anterior to the trachea and recurrent laryngeal nerves.
A very specific, thorough removal of central nodes.
This extensive dissection is done regardless of whether the nodes appear clinically involved, as the rate of microscopic lymph node metastases to the central compartment, level XIV, is exceptionally high, ranging from 50% to 80% in both the ipsilateral and contralateral compartments, even when not palpable.
High chance of hidden mets there, so take them out regardless.
Intraoperative surgeon inspection alone is simply unreliable for detecting these microscopic metastases. The lateral nodal compartments, levels Ti and V, are also frequently involved, and a patient-tailored approach for lateral neck dissection is decided based on factors like the primary tumor size, the extent of central compartment involvement, and the baseline calcitonin CEA levels.
Removing side nodes depends on the situation.
Careful attention is also paid to preserving the parathyroid glands, ideally in situ, or cryopreserving and autotransplanting them if necessary to prevent low calcium levels after surgery.
Try to save the parathyroids during MTC surgery.
Now let's talk about prophylactic thyroidectomy. This is truly where the strong genotype-phenotype correlation in MEN2 provides an incredible advantage and is a prime example of personalized preventative medicine.
The preventative surgery based on the gene test.
Exactly. The goal here is to prevent metastatic spread and significantly improve overall survival in RET mutation carriers, as virtually all MEN2 patients will eventually develop MTC. Improved survival is strongly linked to performing thyroidectomy and sentinel node dissection when calcitonin levels are undetectable or very low, and crucially, before any clinically apparent MTC develops.
Best outcome if done before calcitonin rises or cancer is visible.
Therefore, prophylactic thyroidectomy is highly recommended for infants, children, and adolescents, with precise recommendations stratified by the specific RET mutation present.
Timing depends on the specific mutation.
The 2015 American Thyroid Association, ATA guidelines, categorize risk based on the aggressiveness of the MTC associated with specific RET mutations.
Right.
There are 3 categories, allowing for incredibly precise, tailored management. ATA highest, ATA HST, ATA high, ATA-H, and ATA moderate, ATA-MOD risk.
ATA highest, high, and moderate risk categories.
Okay, the ATA highest risk category, which includes all MEN2B patients with the M9ATT mutation.
The most aggressive group.
Prophylactic total thyroidectomy is recommended even before their first birthday, specifically under 12 months of age.
Surgery before age 1. Wow.
This early intervention is critical because of the highly aggressive nature and early onset of MTC in this group. The decision for a central lymph node dissection at this very early stage depends on whether there are clinically suspicious nodes and, importantly, the surgeon's ability to preserve the delicate parathyroid glands.
Central nodes maybe, depends on the situation in infants.
Operating on these children at an earlier age significantly increases the likelihood of a biochemical cure, meaning undetectable calcitonin levels, and dramatically improves long-term survival. Given that most will develop MTC by age 16 and often present with the characteristic MEN2B physical phenotype, like mucosal neuromas, screening for MEN2B or MTC should be considered in any child presenting with these features.
Early surgery, best chance of cure for MEN2B.
The ATA high-risk category, encompassing mutations like codon C634 and A883F,
High risk, but not highest.
recommends prophylactic total thyroidectomy by age 5 years or even earlier if serum calcitonin levels begin to rise, suggesting more aggressive disease is already at play.
Surgery by age 5 for high risk.
For these patients, the inclusion of a central lymph node dissection is based on preoperative calcitonin levels and a careful intraoperative inspection of the lymph nodes. Screening for pheochromocytoma and primary hyperparathyroidism, which are common in this group, should begin by age 11.
Start screening for pheo and parathyroid at 11 for this group.
Finally, the ATA moderate risk category includes all other RET mutations, including those associated with FMTC.
Moderate risk includes FMTC.
For this group, prophylactic total thyroidectomy is recommended after age 5 years, with the precise timing often guided by annual calcitonin levels.
Surgery after age 5, timing based on calcitonin for moderate risk.
For this category, annual screening, including a physical examination, neck ultrasound, and calcitonin measurements, should begin at age 5. The type of operation, whether a total thyroidectomy alone or with a central lymph node dissection, is individualized based on these calcitonin levels.
Start screening at 5, surgery timing flexible based on calcitonin.
Notably, patients operated on when their calcitonin levels were below 30 pgml have shown no persistent or recurrent disease in long-term follow-up studies, highlighting the effectiveness of early intervention.
Operating with low calcitonin works really well.
Screening for pheochromocytoma and primary hyperparathyroidism in this category begins at age 16.
Start screening later for pheoparathyroid in moderate risk group, age 16.
The outcomes for familial forms of MTC are highly dependent on the patient's age and the disease stage at the time of surgical management. In patients with MEN2-associated MTC, overall survival at 5 and 10 years has been reported as an excellent 100% and 94% respectively,
Excellent survival with proper management.
with biochemical cure, the normalization of calcitonin to undetectable levels, strongly linked to improved overall survival. Because a total thyroidectomy is performed, all patients with MTC require lifelong thyroid hormone replacement.
Lifelong thyroid pills after surgery.
Lifelong follow-up is also essential, with calcitonin and CEA levels measured every 3 months initially after surgery, and then every 6 to 12 months if undetectable to diligently monitor for any recurrence.
Lifelong monitoring with blood tests.
When it comes to recurrent and metastatic MTC, which is MTC that is spread, about 50% of patients will unfortunately experience persistent or recurrent disease after their initial surgery.
Half still have recurrence despite initial surgery.
This is often identified by a palpable neck mass or as steadily rising calcitonin levels. If calcitonin levels are significantly elevated or rising, a thorough evaluation for distant metastatic disease is crucial. Regional recurrences, those limited to the neck, are best managed with repeat compartment-oriented operations, which can often help achieve a biochemical cure and significantly improve survival.
Neck recurrence often needs more surgery.
However, beyond surgery, options are limited. Postoperative radioactive iodine is not indicated, as we discussed, because C cells do not take up iodine.
Still no role for radioactive iodine.
External beam radiation has shown little benefit for neck recurrence and does not improve overall survival, although it may provide palliation for painful bone metastases.
Radiation mainly for symptom control in bones.
Traditional cytotoxic chemotherapy has historically had low response rates and is not considered a first-line treatment.
Chemo doesn't work well.
The good news is that our deeper understanding of the genetics of MTC has led to the development of targeted therapies, primarily tyrosine kinase inhibitors, or TKIs.
Targeted therapies, TKIs. This is where the hope is for advanced disease.
Exactly. Vandetanib, for instance, is FDA approved for metastatic MTC and has shown to significantly improve progression-free survival in clinical trials by targeting the specific pathways that drive MTC growth.
Vandetanib is one example that can help slow things down.
Yes.
Beyond medullary thyroid cancer, MEN2 often brings other significant challenges, notably pheochromocytomas, which demand careful attention due to their potential for serious and even fatal complications. How do these tumors fit into the complex picture of MEN2 management, and what makes them such a critical focus?
They are, without exaggeration, critically important. Pheochromocytomas are tumors that arise from the chromatin cells of the adrenal medulla, which are located in our adrenal glands atop the kidneys.
Tumors in the adrenal glands making adrenaline.
These tumors lead to the excessive secretion of catecholamines, which are hormones like adrenaline and noradrenaline. Patients typically experience symptoms related to this excess, such as sweating, tremulousness, headaches, flushing, palpitations, and intense anxiety.
Classic adrenaline surge symptoms.
While they can be diagnosed in children and adolescents, the typical age at diagnosis is in the 30s or 40s. The single most crucial point regarding pheochromocytomas in MEN2 is that they must be identified and medically managed before any other surgery, especially thyroidectomy for MTC.
We keep coming back to this. Deal with the pheo first.
It cannot be stressed enough. Failing to do so can lead to a fatal intraoperative hypertensive crisis, a sudden dangerous spike in blood pressure during the operation. Evaluation is done by measuring plasma or 24-hour urine metanephrines, which are breakdown products of these hormones.
Check metanephrines in blood or urine.
If a pheochromocytoma is found, an adrenalectomy, which is the removal of the adrenal gland, is almost always performed first to normalize catecholamine levels before proceeding with any other planned surgeries.
Adrenal surgery first. Period.
Compared to sporadic pheochromocytomas, those in MEN2 patients have some distinct characteristics. They tend to occur at a younger age, are often bilateral, meaning they appear in both adrenal glands in about 50% of cases.
Younger, often both sides involved.
And patients often have higher baseline metanephrine levels. In a significant number of cases, pheochromocytoma is diagnosed synchronously or at the same time as MTC, which reinforces the absolute importance of rigorous preoperative screening for all MEN2 patients.
Found together often, so always screen.
The penetrance of pheochromocytoma, meaning the likelihood of developing it, varies significantly with the specific RET mutation type. For example, it's 88% by age 77 for codon 634 mutations, whereas all patients with a codon 918 mutation found in MEN2B will have developed a pheochromocytoma by age 56.
Likelihood depends on the mutation again. Very high for some.
Fortunately, MEN2-associated pheochromocytomas tend to be benign in the vast majority of cases, with fewer than 5% being malignant. However, given the potential for recurrence and the high likelihood of bilaterality, lifelong monitoring is absolutely essential.
Usually benign, but need lifelong checks because they can come back or show up on the other side.
Exactly. All patients with MNN2A or MNN2B should be diligently screened for pheochromocytoma. Recommendations for screening are carefully stratified by the ATA risk categories we discussed. ATA highest and ATA high-risk patients should begin screening at age 11.
Start screening at 11 for HST and H risk,
while ATA moderate-risk patients begin at age 16.
Start at 16 for MOD risk.
This involves annual measurements of plasma-free metanephrines and norepinephrines, or 24-hour urinary metanephrines and norepinephrines. Any abnormalities, such as consistently elevated levels, should prompt further investigatory imaging, typically a CT or MRI of the abdomen, to evaluate for an adrenal mass.
Annual blood urine tests, span if abnormal.
Surgical resection is the treatment of choice for confirmed pheochromocytomas. The preferred procedures are minimally invasive laparoscopic or retroperitonioscopic adrenalectomy, which involves small incisions and specialized instruments.
Minimally invasive surgery is preferred. Laparoscopic.
These approaches are associated with shorter hospital stays and less postoperative pain compared to traditional open surgery. For larger lesions, or those with radiological evidence of invasion, an open adrenalectomy may still be necessary.
Open surgery for bigger or invasive ones.
A major concern is the high likelihood of bilateral tumors or recurrence over time, potentially requiring multiple operations. Therefore, when feasible, a cortical sparing or partial adrenalectomy is performed.
Try to save some adrenal tissue if possible. Cortical sparing.
Yes. This means removing only the tumor while preserving as much healthy adrenal tissue as possible to avoid adrenal insufficiency. especially in patients who have had the contralateral adrenal gland removed or those with small tumors where normal adrenal tissue can be preserved.
To avoid needing lifelong steroid pills.
Exactly. Approximately 90% of patients remain steroid independent after a cortical-sparing adrenalectomy. The decision to perform this type of surgery is highly individualized, balancing the risk of recurrence with the significant benefit of avoiding lifelong steroid dependence.
Individual decision based on risk-benefit.
Crucially, all patients undergoing surgery for a pheochromocytoma must receive appropriate preoperative preparation, typically with an alpha blocker or calcium channel blocker, to safely manage blood pressure fluctuations during the procedure. Our source illustrates these approaches in Figure 41.7.
Need blood pressure meds before pheo surgery too. Alpha blockers.
Essential. Finally, let's discuss primary hyperparathyroidism, or PHPT, in MEN2. This occurs in up to 1/3 of MEN2A patients.
PHPT again, but only in MEN2A up to 1/3.
However, it's a critical distinguishing factor that PHPT is not found in patients with MEN2B or FMTC, so screening and surveillance for PHPT are specifically not indicated for those groups.
No PHPT in MEN2B or FMTC, don't screen them for it.
In MEN2A, the likelihood of developing PHPT is predictable based on the specific RET mutation, with codon 634 mutations in the ATH category being the most common and associated with an earlier onset of PHPT.
More likely with certain mutations like 634.
Screening for PHPT follows the same age recommendations as for pheochromocytoma in MEN2A patients. ATH category patients should begin annual testing of calcium levels in PTH at age 11, and ATA-MRD category patients at age 16 years.
Screen starting at 11 for high risk, 16 for moderate risk, same as pheo screening ages for MEN2A.
The surgical management of PHPT in MEN2A has evolved significantly. Historically, options included subtotal parathyroidectomy or total parathyroidectomy with autotransplantation.
Like in MEN1 initially.
Right. However, the current approach increasingly favors the removal of only abnormal appearing glands, guided by real-time intraoperative PTH measurements to ensure biochemical cure while minimizing the risk of hypoparathyroidism.
Now it's more focused. Only remove the bad ones.
Often, yes.
Imaging helps, especially if they've had neck surgery before.
Precisely.
Wow, what an incredibly detailed and thorough journey through the multiple endocrine neoplasia syndromes. So what does this all mean for you, our learner, and how can we put all this complex, yet now deeply understood information into perspective?
That's a lot to take in, for sure.
We've covered the profound impact of genetic understanding on diagnosis, surveillance, and truly tailored treatment, allowing for a level of precision that was unimaginable just a few decades ago.
The progress has been remarkable.
We've seen how the incredible precision allowed by strong genotype-phenotype correlations in MEN2, particularly with the RET gene, enables clinicians to predict the disease course and proactively intervene with potentially life-saving surgeries like prophylactic thyroidectomy.
That predictability is key for MEN2.
This stands in stark contrast to the more surveillance-focused approach often necessary for MEN1, where such clear predictive genetic roadmaps aren't typically available.
Right, MEN1 requires more broad surveillance.
The overarching theme here, the core takeaway for anyone seeking to master this field, is the critical importance of proactive screening and early, precise intervention, especially for conditions like medullary thyroid cancer and MEN2, where early surgery can prevent metastatic spread and significantly improve survival.
Early action makes a huge difference. If we connect this to the bigger picture, the evolution of men management is a powerful testament to the ongoing advancements in scientific discovery and the incredible impact of personalized medicine.
Absolutely.
Identifying a mutation in either the MEN1 gene or the RET gene offers clinicians an invaluable tool to predict the likely course of the disease over time and to tailor care to the individual patient, optimizing outcomes in ways that were previously impossible.
Tailoring care to the gene.
This genetic insight also offers profound benefits beyond individual patient care, extending to entire families. For families with known kindreds, confirming the absence of a mutation in unaffected relatives can avoid lifelong, unnecessary, and often anxiety-provoking testing.
A negative test is incredibly reassuring for family members.
Absolutely. Conversely, for those who are indeed carriers, it provides crucial, life-saving guidance for meticulous surveillance and timely intervention. As we continue to learn even more about the intricate pathogenesis of these diseases, our surveillance and treatment strategies will only become more refined, leading to even greater improvements in the lives of those affected.
Constant improvement based on deeper understanding.
So as you reflect on this deep dive into the MEN syndromes, Consider how our rapidly advancing understanding of genetic mutations, as so vividly exemplified by these complex conditions, will continue to reshape not just cancer treatment, but fundamentally transform preventative medicine across countless diseases in the coming decades. What other conditions, currently managed symptomatically, might one day be tackled at their genetic root, preventing them before they even manifest? The future of medicine truly is in our genes.